There are a number of exciting presentations looking at BTK inhibitors at this year's ASH. The most practice-changing, in my opinion, is the phase 3 Alpine trial. So this is the trial that compared the use of zanubrutinib to ibrutinib in the relapse refractory setting. We got an early look at this comparison at EHA in 2021. However, the big limitation is that that study had very short follow-up, just over a year. So we will be able to see the final analysis of this trial, which shows a superior progression-free survival for the zanubrutinib-treated patients compared to the ibrutinib-treated patients. The other important aspect of the comparison is that zanubrutinib was shown to have improved tolerability, which I would say is encouraging, especially with the lower rates of atrial fibrillation and flutter. It also had a lower percentage of patients who discontinued as a result of treatment-related side effects. A few curious findings of the study, in my opinion, are that the ibrutinib-treated patients had a pretty short progression-free survival compared to what we may have expected based on other studies examining ibrutinib in the relapse refractory setting. Their progression-free survival was around 35 months. When we look at another relapse refractory trial, Elevate-RR, which has been published, the median PFS in that group for ibrutinib was 38 months, but that actually was a population focused on individuals with high-risk cytogenetics, whereas Alpine took all comers. Nonetheless, zanubrutinib looks like a really great drug, definitely more tolerable, and also superior PFS based on the analysis this year. So there are two newer types of BTK inhibitors that we've seen at prior meetings that we'll also get updated presentations on. So one is pirtobrutinib. So this is a non-covalent BTK inhibitor that has been shown to demonstrate exciting efficacy in the post-covalent BTK setting based on the phase 1/2 Bruton trial. So in the CLL world, there are two abstracts looking at pirtobrutinib that are updated analyses from the Bruton trial. One will be demonstrating essentially longer follow-up for those CLL, SLL patients that were enrolled. And what it shows is that the drug continues to have excellent tolerability with low rates of discontinuation, around 2%. And we have now also reached the median progression-free survival for the Bruton trial for CLL, SLL patients, and that is just under 20 months. The subset of patients that are termed double exposed or double refractory, meaning they'd been failed by a prior covalent BTK inhibitor and venetoclax, those patients have also had updates in the median PFS for their response to pirtobrutinib, which is 14 months. This represents a major advance compared to what therapies we currently have available off the shelf, which we know perform very poorly in that very difficult to treat subset. And some examples there are PI3 kinase inhibitors, chemoimmunotherapy, which based on real world studies have PFSs more along the 4 to 5 month range. We also will get an updated look at the Bellwave trial. And so this is the trial looking at the other non-covalent BTK inhibitor, nemtabrutinib. This is, there are actually even more than Pirto and Nemta, but these are the two that are the furthest along. And the Nemta trial has enrolled a good number of patients, and we're also seeing a good, respectable overall response rate from that trial, but quite a bit less in the way of numbers when compared to pirtobrutinib. And then there's the newest class of drugs that target BTK, but in a very different way. This specifically is the Nurix compound that instead of inhibiting BTK, it blocks that pathway by actually doing targeted degradation. And so very interesting conceptually. The numbers on that are pretty small, but I'm really excited to see that move forward in its development as well.